Nordinah. Thank you so much for the invite of the IIUM. A blessing and, of course, a grace to be invited. So, I just finished my 3 years term as the president of the Philippine Guidance and Counseling Association. This is the accredited integrated organization for counselors in the country. In the Philippines, we have almost 5,000 counselors. So part of my work with ACA, I became the mentor and the branch leader for the American Counseling Association, as we are part of the branch of the American Counseling Association. And of course, I'm very happy to meet all of you. Dr. Fred, we've been working for a lot of times, no, and we also invited him before. Currently, I'm the business manager of the Philippine Guidance and Counseling Association. Part of my work in the academe is I'm a full professor and researcher of the Psychology and Education Department of the Far Eastern University. In my work in the industry, I'm the mental health consultant of the Office of the President of the Philippines, Malacanang. And in my community work, I'm working as the senior technical consultant of the Unilab Foundation. It's a foundation that we've been creating programs, researches, manuals for the poor from a multi-sectoral and a multidisciplinary approach. Of course, I'm also a mom. I have 2 kids now, and I'm also a researcher doing some researches. And I think we have collaboration also with Dr. Frederick for our research in the Humility Project, if I'm not mistaken, because we're not meeting face to face. Yeah, so great to meet all of you. Okay, Saiful, Dr. Nordinah, Dr. Fred, Yvonne, no, and all the people watching. Thank you.
All right, thank you, Dr. Hudson. I like the part when you said I'm also a mother of 2. That is the never stop responsibility as a woman, right?
Yeah, and
All
we
right.
love as
So
well.
thank you, Dr. Hudson, again. Yes. All right. So with that, can we move to Ms. Yvonne, a bit about your background and also your contribution, involvement in counseling and mental health in the country, please?
Sure. I respect all the mothers. I'm not one yet, but I do respect all of you. It's my pleasure and honor to be here. I am a bicultural person. I grew up in Taiwan, but I was trained and educated in the United States, in California. And right now, my job in Taiwan, I'm the founder of Taiwan Multicultural Counseling Association. So this bicultural background reflects on my work as well. So the association, what we are trying to do in Taiwan is 2 directions. One is the localization and decolonization of psychotherapy in Taiwan, because we have a very diverse society, but multiculturalism has never been a hot topic in the country, unfortunately. But right now we're trying to implement a lot of training courses and support groups for counselors in Taiwan to start talking about multicultural counseling and social justice. So the other direction is English counseling, which is also a pioneering act as well, because we have a lot of population in Taiwan who are expats, Asian Americans, or cross-cultural families, or Southeast Asian immigrants. So the other direction is English counseling. So I'm very excited to share all my work and the challenges with you later on. Thank you.
Okay, very interesting. Thank you for that, Ms. Yvonne. All right. So as the host, can we have Mr. Saiful Reza a bit about your involvement and work?
Thank you, Nordinah, and it's a great pleasure to be here. And thank you so much for the participation from the Dr. Frederick, Dr. Hodgson, Ms. Yvonne. Glad to have this kind of discussion, so we may actually learn the best practices and getting new ideas from you guys. Almost the same that we are quite what we call, we have a we actually in the same region, but perhaps we are actually having a different thing, speaking about culture, speaking about the challenges. And well, my background, I started as a student volunteer for the counseling center. Then I became a counselor back in 2006. Now for plus minus 70 to 18 years, currently leading the counseling and career services center. So basically, I got two important portfolio. The one is speaking about the well-being of the students, and the other to support the graduate employability of the university. And as the university counselor, I think most of you perhaps could predict the main client that we are facing. So basically, we are dealing with youth, but actually the center also we are opening our door for kids of our staff. Of course, we are dealing with the staff as well. We are accepting our society. I mean, the public people can also walk into the office, get the services from our center, and to expand our services to get a variety of diverse clients to empower our professionalism. The office also run as a consultant. So basically, we also deliver the employee assistance program to some other companies. So that's how we are actually delivering our services across our main population, society, and also corporate companies. And I'm glad to share what are the things that we are doing and learn from you guys. Thank you.
Okay, thank you, Mr. Saiful. So, panelists, we are about to start our first round discussion, right? So, I just would like all of you to share a bit about the current situation of mental health, particularly in your country, and also, if possible, in relation to the Asian, because we are come from this part, right? Because according to WHO report, 12 billion working days are lost every year to depression and anxiety alone. This is based on report from WHO in 2019. So looking at the numbers and also the current situation, meaning to say the awareness and also the issues of mental health has been what do you call that, handled by the government or the individual as important as the physical issues as well. So can the panelists discuss and throw your view and ideas on the issues of current situation of mental health? Please, I pass to you. Who would like to start? Okay, Dr. Hodgson, yes, I can see
Yeah. Okay, so I
that.
think
Thank you.
of course our government is also getting worried about the increasing number of mental health concerns because we really have an increase of mental health concerns after the pandemic. So of course the suicidal cases, the high rate of anxiety disorder and depression are definitely getting higher now in the Philippines, especially among the adolescents now. So our response for that on the part of the PGCA, okay, on the part of the Philippine Guidance and Counseling Association, we were called by the Senate because of our proposal. So we've been working for this for how many years? And that is what you call the creation of the Basic Mental Health Act. So the Basic Mental Health Act, and of course the creation of mental health programs for the colleges and universities. So prior to that, in 2018, we have already the Philippine Mental Health Law, and we also have a law for psychology programs and guidance counselor programs for our core processes, and of course our scope of practice and ethics. So in 2018, we had the Philippine Mental Health Law, the creation of mental health programs not only in the school but also in the community and in the industry. And now with all of this that are happening, we also made some proposals with our Congress. And now, fortunately, and we are very happy that our basic mental health law that will create care centers for all the schools in the country, and definitely the creation also of items or what you call vacancies for guidance counselors and other mental health professionals. And of course, the increase of compensation for counselors. We already had the third and final reading of the law. Okay, and we are just waiting for the approval, and this will definitely create concrete and comprehensive programs in the school. Okay, and of course, it will also add a lot of vacancies for counselors, psychologists, psychometricians, and other mental health professionals for the schools. Okay, so that is our response because of the government were definitely alarmed by the increasing number of mental health concerns. So in the Philippines, in the elementary department of the public school, it was reported last year that we had almost 3,000 of unfortunately completed suicide. No, and we cannot close our eyes to that. And a few weeks ago, we had two alarming cases of suicide that happened in a university, a grade 7 who jumped. No, and sorry for the trigger warning, who jumped inside the school, and another one after a few weeks, also a student who jumped also in another school. So this is a very extraordinary incident that are definitely happening in Filipino families now. So we have to really expedite our policies and our laws. Okay, so our concern is we have a really a low process of legislation in the country. No, the years are definitely long, and we are very fortunate that our university are supporting that. Of course, the PGCA and other school stakeholders, and this is really somewhat the silver lining of the implication. No, that we really have to do something, and our work now is really more for legislative agenda. Okay? So that it will that definitely there will be really concrete response. Okay? So thank you.
So, Dr. Hodgson, that is what happening in Philippines situation in regards the practice of counseling and also on the awareness and education
Yeah,
of many mental health issues, especially in the issues of committing suicides. And the government is also emphasized a big role in all levels, right? Because you mentioned about the school setting and the public setting and university setting as well. All right.
yeah,
Okay.
yeah.
Thank you.
When
How
I
about
became the
from
yeah, yeah, when I became the president before in 2018, so we already had the position paper, and it's really a long process. No? So it's 6 years in the making, and I do hope that it will definitely pass already and had the approval. Thank you.
But you mentioned just now is it's on the third hearing and also the final results will come soon, right? Especially on the
Yeah.
X.
Mm.
Yes. It seems that some of the parts Philippines move much more forward than I don't know, maybe Malaysia. All right. Okay. Thank you, Dr. Hodgson. Maybe we can share from a view from Dr. Frederick and Miss Yvonne and Brother Saiful as well.
All right, Dr. Dina, maybe I can go sharing what happened in Malaysia. All right, so speaking about the Malaysia setting, I would say many years back, we were dealing with stigma. People actually quite hesitate to get a professional assistant. They're afraid to open up their issues, and people perhaps could label them badly. But recently, we can see gradually people are more open, especially our youth and youngsters these days. They're quite open speaking about their mental health condition. They don't hesitate to looking for a professional assistant. So what happened at the universities, I would say that every day we got a client, they walk into the office, and I somehow I can say that um, this is my concern as the director. I am worried that my counselor even suffering from burnout because almost every day, and they quite angry actually if we were to cancel or reschedule the appointment. It's totally different from before. So they really look forward. And we can see that how the local artists these days, especially the youngster, they're creating a new song, and most of the song get viral and speaking about the mental health. And we can see this scenario how the youth also, sharing most of the concern through their social media. They're using the social media as a platform to do ranting or expressing whatever frustration that they have. But somehow we can see the different here with the previous. It's not previous generation. We can see the different here in terms of the acceptance how they're dealing with the seniors. That is our challenge here because not everyone accepting mental health. Some of them may perceive that these people they are actually attention seekers perhaps, and the way how people dealing with the mental health maybe in terms of the intervention, in terms of how to solve the problem merely solidly go with the religious perspective, we still facing that. um, but speaking about the what we call the support from the government, we can see tremendous initiative efforts being delivered. We can see how the enforcement to actually empower this kind of thing at the school setting, at secondary setting, the university setting, and we can also see how many companies these days they are also celebrating the mental health day. They also start hiring counselors, clinical psychologists to overcome the burnout issues, to overcome whatever workplace related stress issues. More and more companies start hiring consultants for the employee assistance program. So we can see how things keep on improving, and we're not denying that the number of suicidal cases increasing, but we can see also improvement happen at the media setting. For example, many years back, media simply publish whatever cases. But now I would say that they got better idea on how to cover the stories. Not all story being published publicly because they're really concerned about the ripple effect. And we can see at the country more and more NGOs being established and more effort to get more people understand about the mental health, and they are actually empowering this mental health advocates program a lot, so that the nation getting a better ideas. When we have a better ideas, we may support those who struggling at our best level. I think that's all uh, for the Malaysian setting. Thank you.
Yes, thank you, Mr. Saiful, for the sharing of the involvement of Malaysian government and also the NGOs as well. We can see, I have to agree that but Mr. Saiful said that in Malaysia, the advocates program is mushrooming, especially after the pandemic. This is what I always tell my client when I'm doing the counseling session. Because why? Before this, talking about counseling, talking about mental health is considered as taboos. Now people are more open up and would like to share more about that. All right. And we have a proper channel to have the assistance and also the guidance from the legal counselors. All right. So can we proceed with the next on the current situation with regards to mental health? Maybe Dr. Frederick and Miss Yvonne can continue.
Yeah. Listening into the developments in the Philippines and Malaysia, well, actually, it's kind of a similar story, right? It's a lot of moving pieces, a lot of course, we can trace back, I think, to what the opening the moderator have shared about how perhaps, mental health and mental well-being perhaps hasn't been equally the focus to physical health many years ago, which may have kind of been one of the underlying problems that, of course, the pandemic actually bring things to the foreground. Yeah. So I think it's important to acknowledge that a little bit and to see how that though we talk about the biopsychosocial and spiritual model, this and that, but for many years we haven't focused a lot on the psychosocial bit of things. So having said that, I mean the development is also very very uneven, if you like. across the people, public, and private sector in Singapore. But we are definitely a much smaller country in the space, so the developments here tends to be a bit more, perhaps more government driven, if you like. But across the three sectors, these movements are also pretty uneven. We have quite a bit of increase in awareness, at least in the people sector. Very much a lot of ground up initiative, a lot of a couple more agencies are coming out, charities are coming out talking about mental health for different subsectors, right? Could be youth, could be the elderly, and so on. We also see a spike of suicide for elderly, yeah. And we are an aging population. I think Singapore is aging faster than most of the countries represented here. So that is increasingly a problem. We have increase in youth suicide. So I always tell people we are kind of burning from both ends, if you like. Yeah, so that as well. So there's quite a bit of ground up, right? Initiative to bring attention and awareness. I say this recently, partly because Singapore has established a school-wide school counselling system about 15-20 years ago. So therefore, the generation that now we are seeing at universities or the workplace, the adults, the working adults, like Saifu have talked about, are more willing and more less stigmatized about coming for counseling and therapy, yeah, which is a good thing, right? So the awareness is really quite high across the board. Similarly, in the private sector, with more cooperation, employing employee assistance programs. And then, of course, in the public sector, the government has been ramping up its efforts, and the latest being the outcome, or rather the plan that was being developed by the inter-ministerial or inter-agency task force on mental health, that actually trying to streamline and to categorize the provision of mental health care through a tier system, where psychiatrists, psychologists, counselors, or even peer helpers roles, and and the tiers can be more neatly kind of categorized, so that the right service can be provided to the right people who needs them. So that's definitely something else the government is rolling out, and it has just been announced. On the counseling front, because as we talk about mental health, it's a lot of stakeholders and other professionals, right? I just mentioned about social workers, psychiatrists, and counselors and psychologists and so on. But just on the counseling front, there is a long project that is coming to materialization, which is the Counsellors Skills and Competency Framework, that is going to be rolled out very soon. So that again strengthen the country's response to mental health challenges from an angle of having perhaps more standardization in the skills and competency among counsellors. Yeah. So these are different pieces that's going on. Of course, the universities, the schools, even the social services are increasing their capability in managing mental health and suicide-related cases. But I want to say something about awareness, right? Because the increase in awareness have to be because of the uneven development. So sometimes, as Saifu has mentioned, the increase in awareness may cause increased demand. And then some of us are involved in the supply chain thing of the end of things, supply of counselors or different programs and so on and so forth. There will never be an equal match, right? I mean, you either, so more often than not in our space, the supply outstrips the demand. Yeah. and we have to play a bit of a catch up, to ensure we have the funding, the program. Recently, about a year or two ago, we had we just started being involved in a very exciting program with the Family Justice Courts, right? Where we come together in their model of something called therapeutic justice, right? Where psychiatrists, psychologists, and counselors come together to support some of the court users. So these are more such programs that's coming up across, but like I say, it's very uneven. So you will need time, I suppose, for years things to pan out. So one thing Singapore doesn't have, and we look forward to have, is the situation you have in the Philippines and Malaysia, where counseling is a regulated profession. I think counseling and psychology is a regulated profession. I think in Taiwan, psychology is regulated profession. Maybe Yvonne can share with us a bit later. I just look forward to learn about the Taiwan situation as well. So in Singapore, it is not. So counseling is not. But the government, as I mentioned, the skills and competency framework is being increasingly involved. And we do look forward to that step to regulate mental health practitioners. Like I say, so much demand and awareness, but supply of quality mental health practitioners, right, is important. It's just not just the numbers, right? And you have counselors who don't really do a lot of mental health work. You have social workers who don't do a lot of mental health work. Similarly, psychologists, right? So I think it's important then perhaps we take the next step, but we shall see, and hopefully if we do take the next step, I have something else to report when we next meet. Yeah. I should just stop there and maybe pass on to Yvonne. Yeah.
Okay, so there's a lot of things that Dr. Frederick said that I resonate, along with the two presenters earlier. I guess for all of us, counseling is a new thing to the country compared to the development in the West. We're just in the beginning stage. So, of course, we would encounter a lot of phenomena. I'm going to start with the good news from the positive. So in Taiwan, we just started to have the license, like Dr. Frederick said, about 20 years ago. This is pretty new, relatively new profession. Like 20 years ago, I was a student. I wanted to go see a counselor in the private sector. I couldn't find one. I could only go to a psychiatrist. But now we have a lot, especially in Taipei. So we have different licenses. Psychiatrist, of course, is an MD. We have clinical psychologists and counseling psychologists. These are two different licenses. They work at similar or different settings. Like clinicals, they work more at the hospital settings or the private practice, and counseling psychologists, a lot of them work at the school settings and the private practice. Our social workers cannot provide counseling, unlike the U.S. system. But what I'm seeing is the lack of a community collaborative model among all the professions, like the police, the hospital, the doctors, and psychologists. Unlike the U.S., our collaborative framework, there's still room for improvement, and that caused a lot of burnout on the counselors' end as well. So the good thing is Taiwan has been relying on the free lifeline, 24-hour lifeline that you can call, and people are using it. Like we have a lifeline 1925. Every year they receive 70,000 phone calls. So there are a lot of resources that people can use. And this year in August, the government actually provided free counseling for youth from the age of 15 to 20. From the age of 15 to 30, they can receive 3 sessions of free counseling in the community. But funding ran out within like 2 to 3 weeks. So you can see the demand is really high. And I want to echo someone said earlier that the youth suicide rate is surprisingly high. Among the age of 15 to 24 is the second cause of death. Number 1 is accident. Number 2 is suicide. And it's 15% of the deaths caused by suicide. And of course, it's an aging country like Singapore. So the government has some senior support programs where counselors will go to the household, to the senior's household to provide counseling. We also see, because of COVID, we passed the telehealth regulation. So now telehealth is legal in Taiwan, which opens a lot of window. We also see the blooming of community counseling centers throughout the country, but it's unevenly distributed. So the challenge is that the stigma, of course, and lacking psychoeducation. So the challenge, I would say, for Taiwan counselors is burnout. And the burnout, very interestingly, a big reason for burnout is full-time school counselors or full-time agency counselors. They have to do a lot of administrative job. When I work at the school, 70% of my time, I had to do admin work. And it takes out a lot of time for me to do counseling. And sometimes they have to do teaching and promotion work as well. So burnout is a big issue. And another reason for burnout is that psychoeducation, we didn't receive it at school or from the government, very rare. So being a counselor in Taiwan, oftentimes the responsibility of psychoeducation is on us. And so it's a tough job doing counseling in Taiwan because we have to translate the Western concept of psychotherapy or psychology and to speak to the culture of Taiwan, which is very challenging. And the resources are unevenly distributed. For example, in Taipei is the capital. So in two cities, Taipei City and New Taipei City, we have a quarter of the population living there. The population is about 6.5 million. And they have almost 100 mental health clinic and counseling centers. However, on the East Coast, like in Taidong County, it only has 2 counseling centers. Very, very few counselors there. So it's really, really unevenly distributed. So I'm going to pause here and then we're going to listen to more feedback later. Thank you.
All right. Thank you, Ms. Yvonne. Sorry, I have some difficulty in my what do you call that? Internet. Sorry for that. All right. So that is a basic about the scenario in Taiwan and also in Singapore. What I can understand is that in your condition, Ms. Yvonne, you have to assimilate how the term of psychotherapy and also the usage of counseling and mental health issues in your country, isn't it? All right. So we have introduced a bit about the setting of what is the current scenario of mental health and counseling in all the countries involved here. All right. So can we now discuss what is the main challenges that all of you as the practitioner and mental health practitioner and counselor are facing? For instance, Mr. Saiful mentioned about the different of stigma that the Malaysian population have if compared to previous and now. And also, Dr. Oxen mentioned about how the government is coming out rapidly with certain acts so that can be implemented in different settings. And also, Dr. Frederick also mentioned about the involvement of the government and then the non-government in terms, especially advocating in the issues of mental health. And also, Ms. Yvonne mentioned about the different of practice and also how to assimilate the multicultural in terms of counseling. So, can we have actually to discuss and to share view on what are the challenges and what are the possible factors that may lead to the challenges in terms of a mental health issue in all your settings? Maybe we can start. Any of the speakers, not necessarily following the what do you call that, the number just now.
Yeah, maybe I'll speak. Yeah, so
Is it the policy or is it the enforcement?
yeah, I think on the part of the Philippines, the scarcity of mental health professionals is one of the major problems. No, we have the licensure for counselors in the country, but we only have almost 2,000 psychologists in the country. And I think for the hardcore clinical psychologists, we only have 100 plus. Okay? For the counselors in the country, most of our guidance counselors in the Philippines are really coming from the school setting. Okay? And we only have almost 5,000 counselors, licensed counselors in the country, and most of them are in the school setting. Okay? And we need to really cater a big number because of the population that we have. In the Philippines, we only have 500 plus psychiatrists in the country. Imagine that, no? The big gap of mental health professionals, and some of them are also overseas Filipino workers, wherein Filipinos are everywhere because also of the lack of compensation in the country. So I think for other Asian countries, these are also the problem, the big gap, no? And now that we are really having a lot of mental health protocols, the big problem now are the mental health professionals who will cater because of the long queue, no? The long queue for psychiatrists, the long queue for our children with special disorders, no? The long queue for EAP, for the employee assistance program. The companies do not also have the licensed one. That's why they go for EAP and they just go for partnership. And of course, because of that, really the big and even our older, I think the stigma is lessened in the Philippines because of a lot of mental health programs and awareness, no? But to sustain a modular program, it will also entail a big budget, no? Not only for private firms, but also for the government. So even though we have the Philippine mental health law, the problem is the budget, no? The priorities of budget is not really for mental health. It's really more for education. So I think we share some problems. Thank you.
So Dr. Hassan, you are saying that also in your country, the non-government also participate a lot because the government budget's allocation is more to education rather than discussing about the issues of mental health and counseling, isn't it? Something like that?
Yeah. Mm-hmm.
Mm.
Yeah,
All
so
right,
we have a multi-sectoral approach. So the non-government organization are also helping. You know, that's why one of my work is into the foundation. So we've been
Okay, Dr. Hassan, still there? All right, thank you for the points, Dr. Hodgson. All right, maybe can we get some response from the rest of the panelists on the issues of the main challenges and also the factors that we considered as the contribution to the challenges that we have as a practitioner?
Yes. I think if we talk about challenges, I think there are a lot of challenges. Of course, I want to echo what Sheila Sheikh has just talked about. It's a supply and demand thing, yeah, again. And I think in Singapore, we face the same issue, but because we're not state regulating psychologists and counselors, although the psychiatrist, of course, is regulated as a medical profession. So we don't even have an accurate number, like what Sheikh can present and say how many counselors we have to the population and so on. The Singapore Association for Counselling, the Singapore Psychological Society has our own register, but it's voluntary register, right? Although we know the numbers is growing. I just said that on TV about a year ago. I say the demand is increasing, but we're also happy to say that the supply is also increasing. But is it increasing in the right tandem? We don't know, right? So it's definitely a better situation than if the supply is also not increasing. So, so one of the issue is in terms of the quality or the training or competency and skills of the supply, right, of the practitioners. That's definitely one of the challenges, and that's why our skills and competency framework is trying to address that. But having a framework and standardization is just the first step. We need to look at how the training and the competency can be built over time, right? We all know it's not just about having a workshop, right? You know, the skills and competency among our clinician needs to build over time with experience and practice and so on. But like I say, there's many challenges. I want to just spotlight on another one that, I mean, among many, I actually feel that I think some of us talked about this just now. I think there's a need to increase awareness of what I call kind of the 3M, right? One is about multidisciplinary collaboration or interdisciplinary collaboration between psychiatrists, social workers, psychologists, counselors, and so on and so forth. I mean, we have to talk about it in a very open manner. These are disciplinary lines, right? And often when you get close to disciplinary lines, it gets a little bit difficult, right, in the conversation. But a lot of the problem or mental health challenges we face with now require us to work together, right, rather than to work separately. And in order to work in an interdisciplinary manner, I also realized that a lot of our counselors or psychologists or psychiatrists and so on, in our training, there's no training to teach us how to work in a collaborative manner, right? We are always very... in fact, sometimes I think it's counterproductive, right? There's a lot of very profession pride, and it seems to say that we can do all, we are, and the other profession is not doing enough. Or I don't know. I do not want to get there. But the point I'm trying to make is that we should at the very beginning, whether we're training counselors, program, master's degree, whatever, or on even nursing, teaching, or social work or psychology, we should have maybe a short module, right, on interdisciplinary, multidisciplinary, and transdisciplinary work, and what does all those things mean. So that's one of the M. The other M I think is important also to talk about is called multimodality. Again, there's a lot of situation where a lot of people will say, oh, for this particular issue, you have to use this particular modality, right? This is the only modality that works, right? And sometimes I find a challenge that why people cannot see that we all know, and we learn this in our counseling course, right? It's not one size fits all, right? Some due to many factors, a certain client with the same condition may not respond very well. So I'm not saying that we should not have some gold standard or, evidence informed kind of modality, right? We should go for that, But when it doesn't work, then we must be ready to change to another evidence informed modality. You must be ready to be reflexive and flexible, right? So that's the multiple modality idea I have. Not like you have. Not like, you put all together like rojak. Some of you know what rojak is, right? Put all things together. It's not like that, but you must be ready to switch. Like, if trauma-focused CBT doesn't work, then can we look at art therapy? For certain population, maybe the non-verbal therapies may work better and so on. Or family therapy for the matter, right? If you have a family to work with. The last M I want to talk about is called multiple intervention. And I think this is where I think what Sheikh also talked about with funding and money, right? So whenever I talk about, and this one, I think I talked about it on really difficult cases, really cases or situation that is chronic or long term, and so on, right? So this is where sometimes we have to recognize that it's not a one-time fix it, right? Even some medical condition is not like one intervention and then that's it, for the rest of your life you're fine. We must recognize that there are times that we have to reapply the intervention. We have to reapply, we have to redo the treatment, if you like, or the intervention. So there would be multiple intervention, right? Multiple times that we have to apply that. And this is particularly for, if you put all 3M together, this is really what I think something we have to focus on when we deal with really, really difficult cases, right? We must be ready to move from modalities. We must be ready to work with different disciplines, and must ready to say that, may have to repeat the intervention, a couple of months or maybe a couple of years down the road, and not think of one size fit all or one time, fix things. Like I say, if we talk about challenges, there's so many, right? I just want to focus on this and say, well, whether we can.
It's freezing, right?
Dr. Frederick? I think we lost him. Dr. Freddy is not online anymore, right? All right. Okay. So because I wanted to respond to his question, because he mentioned about three things, right? The supply and demand things, the multidisciplinary things, and multi-intervention modalities as well. So before I continue with we're still waiting for Dr. Frederick to come back and join us. Can we continue with that question on challenge and the factors as well? Again with Ms. Yvonne. I come back with the question to the panelists later.
Okay. So I echo Dr. Sheila said, the long queue, the long waiting list in our universities. Students often have to wait a couple of months to receive service, and in the hospital too. And there is I'm gonna finish on the three things, and before I move on to the details. So the thing is, long waiting list. The demand and the needs are there. And Taiwanese people rely on sleeping pills and antidepressant a lot. So the number of sleeping pills prescribed in Taiwan is huge. 1 out of 5 Taiwanese are taking sleeping pills, and which is number 2 in the world. And the reason is that medication is so cheap. We have the national health insurance, so they can go see a psychiatrist and get a medication and go home, and it costs maybe $15 to $20, and which is considered very cheap in Taiwan. So it's more accessible versus if you have to go receive talk therapy, it's much higher and it's out of pocket. And the third challenge is, like Dr. Frederick said, we are now working in a collaborative manner. Like in the US, if I'm seeing a client and there's a high-risk client, I can call the police or the ambulance, and the police will show up, and maybe they will provide some quick assessment whether or not to take this person to the hospital, and they will take care of it. But in Taiwan, it's not like that. Counselors work pretty alone. So echoing what everybody is saying, the multidiscipline and the multiple intervention approaches are really, really needed in Taiwan. So the thing about, it's very interesting. So there's a long waiting list. There's a need and demand, but majority of them would rather go to the hospital than go into the private counseling center. So of course, stigma is an issue, but also the cost of talk therapy in Taiwan, because it's 100% out of pocket. And so it's not in the culture. You go talk to someone about your feelings to resolve issue. It's the doing culture. I want to see a quick fix. So sleeping pill might help better. So this is this is what people have been talking about. Like in the US, they have the private insurance. Can we adapt that model or the EAP model? People are starting to talking about that. And one challenge I also want to bring up specifically about Taiwan is the demographic change. So the past 10 years, the demographic in Taiwan changed a lot. We have a big portion of Southeast Asian immigrants and cross-cultural families. And in recent years, we also have a lot of expats or international students from Europe, Africa, and other America or Asian countries. So these people become the minority in psychotherapy. Like in certain counties in Taiwan, a foreigner, okay, even if they can try to speak English, they cannot find any English-speaking counselors. Some counties is 0. Some counties are like 5 people you can go to. But not everybody lives in the big city, and then they have the transportation. So this becomes a big issue. And for Southeast Asian immigrants, we really need counselors who can speak Vietnamese, Indonesian, Malaysian. We almost have none of those. So it's becoming a huge issue. A huge population in Taiwan cannot receive mental health services. So this is a big challenge that we are facing now. So the factor is to become a counselor in Taiwan, it's years of process. You have to finish the internship, write a thesis, and it's very costly because the internship is non-paid. So a lot of working family kids, if they want to become a counselor, it's gonna be a huge financial pressure on the family. And like we said, we need a lot of Southeast Asian counselors. But not every family can afford to send their kids to go to a graduate program and then 2 years of internship non-paid. So I would say one of the factors is financial justice. Yeah, I'm gonna pause here.
All right, thank you, Ms. Yvonne. Very interesting, right? Because you said that number 2 in the world, Taiwan has become number 2 in the world who consume the antidepressant medication a lot, and also the cost of meeting a counselor.
Not antidepressant.
Sleeping pills. All right, sleeping pills a lot because due to the cost as well, right? Because it can easily be retrieved rather than meeting a counselor in the clinics. I am interested to know more about when you mentioned about since Taiwan is mushrooming to the demographic change, where involvement of people from Asia, students from Europe comes, and for sure it comes from different what do you call that, culture, beliefs, and also languages. So you mentioned about the factors, right? So do you mind sharing on how you your organization or your government handling this issue in providing the services towards this new demographic of Taiwanese?
Of course, there's a lot of agencies. They would support, for example, Southeast Asian immigrants, but usually social workers would go to the front line first before counselors. And a lot of times they can receive more resources at that part too. So mostly social workers are working with them. For English-speaking population or foreign language population, I know American government is funding an agency in Taipei. English counselors were on a huge shortage in Taiwan. Yeah, so I myself, I'm one of them, but I have to say, cannot fulfill the demand. The demand is too high. So for my organization, what we're trying to do is to overcome the language barrier, to implement the training on culturally sensitive treatment, culturally sensitive assessment and treatment, and also culturally adapted model. Taiwan has to create its own model to work with its own demographics. Especially Taiwan has war, colonization, and authoritarian ruling. So we have something called cross-generational trauma, which is being spoken a lot in the US, but not a lot in Taiwan. So what we are trying to push the awareness about is we are a country that has a lot of cross-generational traumas and that can impact therapy work in the rooms. So we are trying to modify the Western model to become more locally appropriate, culturally sensitive, creative model for its population.
Yes. Wow, that is very interesting. Like to know that how the government and also the NGOs work in terms of handling these issues, right? Okay, thank you, Miss Yvonne. So can Dr. Frederick is here now with us. Do you have anything to continue?
No, I'm not sure whether I said something I shouldn't. That's why I got cut off. No, just
But you
kidding.
mentioned, but we got the 3 points that you mentioned, Dr. Frederick. It's very well said. All right, just to ask, because okay, can we have Mr. Saiful on the issues of challenges and factors that lead to the challenges?
All right, thank you, Dr. Rina. Before I proceed, I think with permission, I would like to ask further, Ms. Yvonne, speaking about the sleeping pills, because it's quite interesting. In Malaysia, this sleeping pill considered as a control medication. So I wonder what would be the minimum age that somebody can purchase? How about the minors? Could they actually easily get access to these sleeping pills? And the second question, how they can easily get this kind of medication? Is it available at the pharmacy, or they need to get what we call supporting letter from a professional medical officer, things like that? I wonder.
Oh, it's very easily accessible. I can just get off the line right now, go to a clinic or a hospital and get one within an hour. Basically, we need to go see a psychiatrist and tell him the symptoms, and he or she will prescribe the medication, and we will go to the counter, get the medication, and go home. It takes less than half day, and the copay is very low. But I don't think it's over the counter. But every hospital or every clinic, you can go see a psychiatrist and get it. And I have heard it depends on the psychiatrist. It's out of their ethics or professional judgment. I think it is okay to prescribe sleeping pill to minors in Taiwan with doctor's approval.
All right. Thank you so much for the answer. All right. Okay. So, Tina and the fellow friends, speaking about challenges, I do agree with Dr. Frederick. There are so many challenges. If we were to actually highlight all the challenges, but maybe I highlighting the top 6. That I think what are the things we are facing now. Number one, here we are dealing with the youth, and speaking about their resiliency. I think it being discussed a lot at the global level, how we are actually dealing with the current generation. So when we talk about their resiliency, what happened these days, some of them, they could easily diagnose themselves, and that of course create a lot of issues, a big worry among parents. So what we need to do here is actually we need to do a consistent psychoeducation, more mental health advocates needed to ensure that they really have a better understanding what we mean by mental health and what we mean by mental disorder, and how to actually go get a very professional support. All right, so this number one. Well, the second one is people more open talked about the mental health. Still we have a group that actually are not so open, because their backgrounds, their understanding, their upbringing, a lot of things could be a contributing factors. But the issues here, some people, when they are too open, they are actually using mental health as a power cut. We having that kind of issues. They simply MIA, missing, and after a week came back and saying that, okay, I got bipolar. This is a doctor, what we call the supporting letter, and they want number of privilege. So we are facing this. We have students, for example, at the university setting. The moment they got closer to the examination, they simply using mental health as a power card to get certain privilege. So it's our big responsibility and big challenges to ensure that which cases truly genuine that really need for a support. Otherwise, the other part of society, they can simply put judgment that mental health is not so serious. It doesn't matter that people just do for the sake of fulfilling their own desire and try to get their personal goals and whatnot. So we are facing that kind of thing. The third one, I think, almost the same as what being shared by Dr. Sen, Dr. Frederick, when we talked about the professional support here, we still insufficient. For example, my university at our university, we still using this ratio that one counselor equal to 1,500. That is the university setting, but for the school setting, one counselor, sorry, equal to 500 students. But still, it's very difficult for us to actually meet the ratio. For our context, my university, we still having four positions. So we are insufficient of four professionals, by the way. And when we talked about this collaborative manner, as what being mentioned also by Dr. Frederick, we have the issues, but not so what we call not so serious. I can see that some people they are be very professional. They are open. They know how synergize really can produce very good outcomes. But it just matters somehow to coordinate all this profession between counselor, clinical psychologists, and psychiatrists. Sorry, we still improving that. But the serious issues here is actually more about the career development of all the counselors, especially the one who actually join the public sector. They may actually suffer from burnout because of number of initiatives, number of cases that they need to take up, but the career development not seems to be very promising. I don't know whether we can be rich people by becoming a counselor or not. Okay, but for us, and I mean, in Malaysia, the situation like a bottleneck. A person who actually joined the public sector, they still at the position of senior executive, for example, and it has been 15 to 20 years still at the same grade. So that can actually demotivate some of them compared to some other profession. They're so fast, they have a better career development. So that is a big challenge to justify to our government. But somehow the government may have the idea that they don't need more counselors, because if they were to have more counselors, it seems that the society not really fit. Why we need more counselors? So that will be the argument that we need to solve. All right. Again, it has to do with the government policies. That is our challenge as well. And when we talk about policies, sometimes it takes number of ministries to sit down together. For example, when we are dealing with the sexual related things, for example, we need the Ministry of Women and Family, we need the Ministry of Health, we need the Ministry of Education, Ministry of Higher Education. Same goes to the religious department to sit together and to be able to come up with one solid policy that can actually secure, prevent issues. Um, what happened in Malaysia, for example, we have number of boarding schools that youth they staying at school, and this can lead to so many things, which later contribute to the poor mental health and sexual related concerns. But still, we couldn't find out what seems to be the best way to prevent things. All right. Well, at the university setting, there's a number our fifth challenge that I would like to highlight here. At the university, we are dealing with client that we consider adult client. But when they are actually keep on doing self-harming or involving with any suicidal attempt, that really put counselors in dilemma to actually break confidentiality. Of course, we need to break confidentiality. Click is so obvious that we need to tell the parents what happened. But somehow, when we are actually breaking the confidentiality, of course, we are dealing with vulnerable clients. Some of them, they actually put a big blame to the counselors, but somehow we still could see family, parents not really supportive, and yeah, that lead to so many kids and parent related issues. Or somehow the university become like a school setting that we need to actually do a lot of things to parent and kids. And lastly, and of course, I agree also with Dr. Frederick, when we're talking about the counseling competency, we are moving to that. I can see that we couldn't be a generic counselor, that we are actually tackle so many things. It's a high time for us to go by a specialization, and we are dealing with more complexity now. For example, in Malaysia, we are still not having so many counselors declare that.
What the ratio is, but I can chip in and say that as far as school counseling, because most schools in Singapore are kind of under the, kind of run by the ministry, the public school, we're mostly public schools. So there's usually 1 or 2 counselors for a school about 1,000 students, plus minus, right? I'm not sure whether there's an established ratio. As I mentioned, because we don't even have a full list. And I want to echo what Sheila Sheikh is saying, that so we have some ratio, or we have some numbers to look at for schools and universities, but we don't have for the community or the wider adult population. So on this note of numbers, so we are really not well, I really hope that we can come to where you are, where we have numbers and ratios to look at, right? Then before we even talk about bettering those ratios, so we are quite behind. But I do want to say that in meeting the supply and demand needs, there's 3 prongs. One is the numbers and ratio, right? The actual hard numbers, supply and demand. 2 is the skills and competency and roles. I think what Yvonne is talking about, you can have the numbers, but a lot of them are involved in program work and admin work, or, then that's another issue, right? So the numbers may not reflect the actual work done. And also the skills and competency, whether what the numbers you have, are they really meeting the needs in terms of competency and the capability, right? And then, of course, the other part is about, it all leads perhaps to funding, right? Right? That supports all these things we're talking about, whether more numbers, better training, and so on. And the part I talk about multidisciplinary collaboration, this is also another prong of approach where we can look at if we can have greater synergy among the disciplines, right? Where 1 + 1 become more than 2, right? Perhaps that also the impact of our intervention can be improved. But all these are really much easier said than done, right? Because all this require money and time, like competency and skills. You need time to build, right? So there needs really a lot more foresighting. There needs a lot more long-term planning, rather than, I think right now we're seeing a lot of reactive, which is not a bad thing, yeah? So that aside, I want to say about something else. We talk about mental health, mental well-being, which is a little bit more subjective, and then there's mental wellness, right? I thought it's good that we also talk a bit about the preventive work, right? So in terms of mental health work, it's also about the preventive work, peer helping, mental wellness, resources, and resilience, right? Because if upstream, there can be also, again, money and time and resources be invested, perhaps at the downstream, perhaps with lesser demand, right? So all this require a strategic approach, right? Whether nationally or within a city or within a county, and so on and so forth. And I think what we definitely will need more is to deal with some of this issue is leadership, right? From people, public and private sector coming together, to address this. So I'm sorry, I just expanded the discussion a little bit, and just to add on to what I think of just perhaps the numbers. But having said all that, on my end, we don't even have the numbers to start with, right? The ratio to start with. So thank you so much. I've been learning so much from you all.
Okay, thank you, Dr. Frederick. Anybody from the panelists want to add? All right, before we go to our final round, okay, I just wanted to need some response from the panelists. All right, since we are providing providing services to our community, because even though like Mr. Saiful mentioned, that we not only cater the university population, we also cater the public demand as well. All right, and for sure we are dealing with different types of people and different races. All right, I'll give example, like in Malaysia, the most bigger population comes from Malay, and then Chinese, and also the Indians, some of the Aborigines from Sabah and Sarawak as well. So some of the culture practice from certain races, they believe that when they have any concerns, right, it's not so cool if we share the issue with the outsiders, particularly us as a counselor and a mental health practitioner. So how about your practice in your country? Because I believe, like the Philippines and the Taiwans and the Singapore, Malaysia as well, we have different ethnic, different values, different religions as well. So how do we can go to advocates, the counseling service, and also mental health advocates? So anybody can respond to that if you had encountered any experience or any Miss Yvonne.
I used to work on the East Coast with Aboriginal kids. And I noticed it's a sharing culture. It's a very collective culture. They always share everything in their tribes. So counseling one-on-one in the room is a very strange concept to them if they grew up in the village. So confidentiality, even though we provide privacy and confidentiality, some clients, they would rather share with their relatives or friends. It's the opposite. They don't want confidentiality. So I do think we need to take culture into consideration. Just want to answer that question.
You? So you had the experience with the kids and they like to share, isn't it? Okay, any other response? Is that so, Miss Yvonne?
Oh, I forgot to mention, Taiwan is a very collective culture, collective faith.
Right.
So,
okay.
So the Western concept of the self is the individual self. But in my clinical words, I feel a lot of clients, they come, this self, it's a collective self. I'm doing this for my kids. I'm doing this for my family. I'm doing this for my parents. So if we put the individual lens into our treatment goal, for example, the treatment goal is too individualistic, some clients will feel uncomfortable. So, and that's the defense that we need to work with in the beginning of our work. So I think one of the questions you asked is the individual mental health right. And for Taipei, like people who grew up in the capital, yes, they do fight for the individual right. But in the South, in the village, there's no such thing as individual right. So they think in group settings. So that's something that I think that's very interesting that we can discuss more of this.
Yes. Yeah, so Taiwan is a collective society like Malaysia as well. All right, any other panelists want to respond to the...
Yeah, I think on the part of the Philippines, because of the Philippine mental health law, the Philippine mental health law mandates that we are not just only particular about well-being, but we are also particular about inclusion and engagement. Okay? And part of the provisions of the law are definitely social policies, anti-stigma, anti-discrimination. Okay, so the implication of that is in most of the schools, industries, and communities, we have what we call the multi-faith room. Okay, so we all know that the Philippines is a Catholic country. We have also Muslims, but it's really majority Catholic country. So we have really what we call now, as part of the policy and the law that we have definitely inclusion policies, and one of that is the integration of what we call the gender and development programs. The gender and development program should be implemented not only in every school, but in every industry and in every community. Gender development is not just honoring the LGBTQIA. It's also honoring the different cultures, and the different cultures are not just only the different nations, but also the different ethnic groups that we have in the country. Okay, the language, the no to bullying, no to harassment. Okay, we also have what they call the safe spaces law, anchored also with our law. So I think one of the best practices that we have are in different cultures are multi-faith services in the different settings, no? And we in the school we also have to provide specific special programs for the indigenous people. Okay, uh, so to respect also the needs of the indigenous. In the school, we also have what they call the International Student Empowerment Program. On the part of our university, we have different intervention programs for children of OFW, because most of our students are really children of OFW. Most of them are working abroad, international students. We also have programs for scholars. We have programs for at-risk students, especially those with mental health tendencies. So we respect the different diversity of the students, and one of also of the best practices that we have is we had what you call the Peer Organization of the Philippines under the Philippine Guidance and Counseling Association. So I founded the Peer Organization of the Philippines because I do believe that the youth should help the youth. Not all the youth, the Filipino youth, are going to the guidance counselors. So they don't want older people mentoring them. So we had what you call the Peer Organization of the Philippines, wherein we respect different cultures. Okay, and we also have what they call now the gatekeeping program of the race that we are also cascading in the country. This is what they call the race against suicide. We always believe that because of the scarcity of counselors and licensed professionals in the country, we need to also equip not only the community doctors, but also the nurses, the social workers, the teachers, the school staff, no, to also be responsive with mental health initiatives. Okay. So thank you.
It seems that Philippines have a lot of advocates programs, especially involve the community and the youth. It's very interesting to know that. Maybe we can have a more discussion later, Dr. Hodgson and Darius, about different kind and approach from any other countries. It's very fascinating. All right. So can we have from Malaysia and Singapore the response to the question?
Yeah, in fact, I don't know whether some of you know that about in September we have a webinar series in Southeast Asia, where I think we hosted in Singapore, but it's a webinar series with counselors speaking from Thailand, Philippines, Indonesia, Singapore, the Cambodia, and so on and so forth. So I'm just going to share just a snippet about what I've learned. So to start off with, many of these are very big countries. So even even the East and West Malaysia can be quite different culturally speaking, and of course the same with the Philippines. So sometimes I think we say multicultural or contextualization, which is what the topic of the webinar is about. It's a very broad topic, and so one of those things that came out, right, among many things, is about the indigenous care or helping model. So and I always like to say, I go back, this word counseling is being coined from a very Western perspective. In fact, it has a certain Christian or pastoral care roots and so on. But let's go back to what it really was, really is, and still today is called talk therapy, right? Talk therapy. So I'm sure talk therapy has been around in our culture, in our part of the region, in a different form and shape, right? It could be related to religions and faith, or it could be related to the way our society is being structured, right? Whether it's family or collectivists and so on and so forth. So I think, and I agree very much with some of the speakers back then, was that there should be more work into this, right? To trace back and say, what is our talk therapy? We can call it counseling now, but I mean, can we broaden? Can we be more I mean, I say this at the seminar, the closing. I say, can we be more pluralist to include what are talk therapy, right, in our indigenous work, right? Our indigenous kind of talk therapy. And then we broaden this whole definition of what counseling is about, right? For our region, by our region, if you like. So we perhaps don't even, I mean, if we are not colonized in the first place, we don't need to decolonize, right? If we can include them. I mean, I don't think they're competing concepts. And I think there are researchers in our countries all around trying to look into this. I really hope in our lifetime we can see a little bit more inclusion about more Asian type of therapy, right? Talk therapy that is in relation to what we face. For example, some of the countries that represented here, there's a lot of natural disasters, right? Then of course there's a lot of trauma we have to deal with, right? We cannot wait for trauma-informed CPT to come, right? So there must be many thousand, 100 years ago, we must have some way we cope with. So yeah, so I just hope to just plant it here that about this multicultural bit, right? It's not so much fitting counseling into our culture, but I mean both ways. I suppose we have to look at what is already in our culture, perhaps already more useful, right? In some extent, yeah. I just stop there.
Thank you, Dr. Frederick. Mr. Saiful, maybe you want
All right, thank you, Nordinah.
to add on
Well,
some?
I say that most of the points that I wanted to highlight being mentioned already by all the panelists, because after all, we can agree that all counselors, clinical psychologists, psychiatrists, all these three professions, the reason why we choose this kind of profession because we love to help others. So speaking about this multicultural, I don't see big issues here, even in Malaysia. Um, so we basically accepting all people from whatever walk of life. All right. Speaking about the mental health, whatever issues, whatever concerns, despite your different colors, even your sexual orientation, we're more than happy to actually listen, validate feelings, and go what seems to be your concern, goals, and we do support the well-being. But I think we shouldn't confuse here sometimes when we talk about the human rights, what happened, the big challenge in Malaysia because we are a Muslim country, to deal with this LGBTQ IA plus. Um, we need to really understand here in terms of well-being, in terms of the mental health, we are okay with that. But these people sometimes when we talk about the mental health, about the human rights, they're requesting some other things that sometimes create tension among um, what we call the society, especially among Muslim. Because here in Malaysia, we need to understand here we have two different set of laws. Number one, it's just like the other countries, like the civil laws that actually govern the country. Things that we need to obey, things that we need to follow in ensuring that we are actually living in peaceful and harmony. The other one here is actually we have a different law. It's more about the Islamic jurisprudence one, the Islamic law, but this one being implemented to Muslim only. So I think that will be the issue that people always try to create an issue, but speaking about the well-being, mental health, we are actually not having a big issues. But I personally, I miss with our panelists from Taiwan, for example, Miss Yvonne, the moment you join the multicultural, for example, it shows that how important to value and to highlight the differences of cultures. So whatever happened here in Malaysia, I don't think that we have one a counseling association to be more specific, specialized, supporting this multicultural. But maybe way forward, these are the things that we need to improve. As of now, I don't know, Dr. Dina, whether I missed this association or not, but couldn't hear about this before. Yeah, I wish that Malaysia sooner or
About
later we are
multicultural,
more.
Mr. Saiful, you mean?
Multicultural association. Counseling, multicultural, just like Miss Yvonne. I don't
Mm.
think that we have that one, right? So we just have the normal one. It's
I
more
also
about
think the
school
same like you.
setting, drug, family. I don't know about the multicultural, but that's the thing that we not talk so much and perhaps we move towards that. Thank you.
Okay, thank you for your sharing points, Mr. Saiful. So, panelists, we come to the last round. I also open if we have some question from the public, if they have, all right. But my last question for our last round is because all the things that we have discussed thoroughly about the challenges, about the factors, and the conditions specifically in your countries. So like it or not, we are aware that counseling profession and mental health profession has been what do you call it, growing rampantly recently, especially after 2020, right? So and also besides sitting in the counseling room doing the session or do the clinical assessment or clinical work, we also know that we need to do some some programs and acts and steps to advocate the services that we have. The panelists have shared a lot, especially like from the Philippines, Taiwan, Malaysia, and Singapore, on what the government and the non-government has done. All right. Besides the things that you all have mentioned, is there any other suggestion on how to advocate more on the issues of mental health among the public? And also especially in our country, because we know that in our country the citizens come from different background, different types of SES, social economic status. For instance, in the city, maybe they are more aware on the service provided by the counsellor, but not in the village or the suburban. All right. So beside the things that you all have mentioned during the first round, is there any suggestion or plan of action that might be implemented not only in your country? Maybe we can integrate in our country as well. So I pose the question to the panelists.
I actually have something that I forgot to mention is that we talk about talk therapy. Talk therapy is all about talking and language, but Taiwan has changed its official language. My parents' generation. So my grandparents and I speak different mother tongues. So that's a very odd situation among all countries. So in talk therapy today, we use Mandarin, but that's why my grandparents don't go to therapy. They don't speak their languages. And I agree with Dr. Frederick said, we need to identify how people cope. Our ancestors before 20 years ago, how did they cope with the adversity and the trauma and the suffering of the land? They must have come up with some special coping mechanism. So I want to joke about it. Besides religion, shopping therapy works better than talk therapy in Taiwan. Alcohol therapy might be more popular, right? So they have their own ways of coping. So what I'm thinking in today's therapy is focused on healing. Perhaps that we can integrate some coaching element into our therapy, empowerment element into our therapy to kind of foster and build from what they already have and what they are already doing instead of curing. I think this aspect is what I am trying to talk about in Taiwan right now is the positive psychology, the empowering piece here, integrating that into our work. And I want to hear how other people are thinking about that.
How the different talk therapy that they have during our ancestors and now. Now we have emerged to other types of coping. When Ms. Yvonne mentioned about the retail therapy, that is can considered as one of the most effective ways, especially among women. I guess so. Maybe I'm talking based on my experience. All right, the rest. Any suggestion or plan of action in terms of advocating the mental health programs or policy or whatnot?
Yeah, for me, definitely I do concur with Yvonne that there was really a changing landscape of mental health. The symptoms are also evolving. the symptoms now are a product not only of the family, but also the product of the environment and technology. And I do hope that we venture more into an evidence-based practice in counseling and psychology. That we really have to really go for research, especially among the interventions and therapies that we are doing. I also go for really collaboration, and I'm really thankful when I have an invite like this, even though I'm done with my presidency. So I'm really willing to collaborate, no? And we will also be having an upcoming event, no, with Dr. Frederick. November 1, I'll be in Singapore for their program to help. And last year in the Philippines, I also invited some of the leaders of the ASEAN countries with the first ASEAN conference for counselors in the country. And I really go for collaboration. Okay? And not only in the ASEAN countries, but even in our nation as well. Okay? So our practice that we are also using now in the country is, I always believe in professional humility. And of course, I also believe in bravery, no, to really accept what is wrong. That is a professional bravery and intellectual humility to ask for help. That's why in the Philippines, we have what they call the Philippine Council for Mental Health. The Philippine Council for Mental Health is a group of collaborators from psychiatrists, psychologists, counselors, coming from the multi-sectoral and intersectoral approach. Okay, so we have different sectors: government, non-government agencies, okay, funders, private firms who are really collaborating. So it's coming together for multidisciplinary, interdisciplinary, multi-sectoral, for an all systems level approach in the community, the industry, and the school, okay, for a one nation approach. Okay, so we are definitely also in the goal of one child, one family, one school, one community, and one country. So what we are also having is a multi-tiered approach. The multi-tiered approach is, the first level is awareness program. The second level is assessment and gatekeeping. And the third approach is pharmacology and referral system to our specialists, our developmental pediatricians, psychiatrists, and of course, our counselors and psychologists. So that is what we are advocating. And I do hope that last year, it's also our anniversary with ASCON. I do hope that the ASCON will also move forward. It's a community of ASEAN counseling organizations. I do hope that it will move forward because unfortunately it had a halt, no? And we had a lot of already meetings, no, of seminars, webinars like this. I'm always meeting Dr. Frederick because we are a yes women and yes man. So I do hope that it will move forward so that we can have concrete policies, because I'm also learning a lot, no? Areas for improvement, okay, the positive ones, and of course the recommendations that I can also bring to my country. So thank you.
Okay, thank you, Dr. Augustine, for the sharing. All right, because it seems that your country have come out with certain steps in terms of advocating programs and whatnot. All right, in terms of multidiscipline and sectional as well. Can we have from the rest of speakers?
Yeah.
From the gentleman. Yeah.
I think I better say
The
something
ladies
now
have
that-
spoken.
Yeah. I better say something now that she talks about my event, as my symposium that's coming out, as well as the ASCON, right? Yes, I think we're
Yes,
working
maybe you want to
very
share more about that?
Yeah,
Yes.
we are working very hard to move the association. I mean, the proposed association. I know the proposed ASEAN Counseling Organization Network. Right? I always get it wrong. So And like what Sheikh has talked about. So first of all, I like to say that we definitely have to have more such conversation. I said this at Philippines and Malaysia and every places. See, some of the things we talk about are new, but some of the things that we are talking about again and again. One of the things I learned, and I think all of you are the same, being leaders in the fraternity, we have to just keep repeating certain things again and again because the audience is different, right? And the platform is different. So I appreciate such opportunity, like what Sheikh says, we are all yes men and women. We just say yes for most of the invitation as long as our time can permit. It's because we have to keep the momentum, right? This whole discussion about all those things we talk about, right? Whether it's challenges or solutions or whether the multicultural messages, we have to just keep doing that to have the momentum, to have the synergy. So I think let's keep that going, whether it's physical event or online ones. That opened the doors for me to ask you all to speak next time. So better say that. So that's one. Two is if we have the network coming together. I was just telling one of the things that we're going to push along in the next meeting, which is coming this Friday, is for us to have regular or annualized such physical conferences among the ASEAN countries, yeah, and then such conversation can have more layer and momentum. That means each meeting or each conferences can be hosted in different countries, different cities, and then we continue to add on to each of this discussion, and then we move along to more perhaps more pragmatic development, right? Maybe there's coming together of as a association is one, maybe journal writing, more conferences, and so on and so forth. And of course, not forgetting our colleagues from North East Asia. So I like my coming symposium on Thursday. We have a speaker from Hong Kong, and now in this wonderful plenary, we have a speaker from Taiwan. I think apart from the ASEAN region, I think we also have to enlarge our engagement with the wider Asia community. So definitely more conversation, but I know where Sheikh is coming from, because sometimes we keep saying and we then what, right? So but the conversation must continue, while some sectors, and if we can even facilitate our governments to work together a little bit more closely, perhaps through the ASEAN framework, right? Perhaps we can see more things developing across. Yeah, let's just stop there. Thank you.
Frederick, for the suggestion and plan of action. Thank you. Dr. Frederick, you mentioned about the upcoming programs that you have in November. Maybe you can share more about that, because I heard that about the program. Is it the Simplicity webinar? Dr. Kassim will be involving as well.
Yes. So the symposium is is actually this Thursday. So yeah, this Thursday,
This is
2nd
okay.
November.
All right. Yes.
Yeah.
Correct.
So we have two speakers from
second
Malaysia.
November.
We have Professor Malanti from UM, and we have Professor Amalia from UNIMAS. So yeah. And of course we'll have speakers from other countries as well. But what is important is that we're trying to have the second meeting for the ASEAN network on the next day, on Friday, and that's what Sheikh is referring to, whether we can move more things forward. And of course, I'm not in the liberty to commit, given that it's much bigger than Singapore. So hopefully after Friday, Sheikh and I can share with you all more what happened. Perhaps there's more development. I'm quite positive. Yeah,
yes.
Quite positive.
We are happy to. We are more than happy to have the news after the symposium and the discussion and meeting. All right, Mr. Saiful.
All right, so I think it's very short for me. First of all, of course, I do agree with Dr. Sheikh just now. Speaking about the landscape of mental health, we can see the gradual improvement. I think it's globally. We can see the different people become more open. They're looking forward to meet the counselors. So that if we could improve, I think the government or whatever relevant parties could actually invest more to the mental health providers. So speaking about cases, is becoming more complex now, so that there's high need for counselors to upskill their competency. And speaking about competency, sometimes it's quite expensive to go for whatever specific professional certification program. So when we thought about this expensive, but we have no choice, so we need to invest. And speaking about the Malaysian setting, again, like I said, the career should be more promising to all counselors to avoid any burnout situation. So at the end of the day, eventually, we may all suffer from the mental health issues. So we need to also look into this matter. And finally, I agree with Dr. Frederick. I think this is the most important thing here is actually to have synergize the collaboration. And I would love the idea to have the Asian networking. Um, Speaking about next week, it's quite difficult for us to join a last minute information, but I wish that actually next year we're going to join more practitioners to join. So I wonder who's going to be the host for the next year.
We don't know. To be honest, we don't know yet. Yeah, we're hoping to update you when we know.
Yeah. I'm going to notify most of the university counselors. We're also going to have a seminar tomorrow, one day seminar that gather all the university counselors from Malaysia. So we're discussing this thing, but I think there's high need for us to cross Malaysia region. So we go by the Asian. So I love the idea to have the Asian counselors networking. Thank you so much.
Okay, Mr. Taiful, thank you for the response. All right, panelists, it seems that we have come to the end of the program. There's no question from the floor. Okay, so for this two rounds, we have discussed on the issues of mental health, the challenges that we face as the mental health practitioner and providers, and also the plan of action that might be suggested not only our level, but also in terms of the country or to the top of higher level. All right. I would like to take this opportunity to thanks to all the panelists, Dr. Frederick, Dr. Hodgson, Ms. Yvonne, and Mr. Saiful for the very fruitful, refreshing, and encouraging sharing. I really hope that this kind of engagement and discussion will not be the last one. Maybe this is considered as the first. Maybe we should have a series more in future in different platform, not necessarily from this platform, maybe in future. All right. So as last, can we have a group quotation? Lukman ke Ija ni? All right. Thank you. With that, we end our session. Have a good day, everybody, and thanks for everything.
Thank you.
Bye.
Thank you, everybody.
Thank you. Bye.
Thank you, everybody.
Thank
Pleasure.
you.
Keep in touch.
Yeah.
Good luck for your symposium, Dr. Frederick.
Dah keluar dah.